Then if we go on to the next slide, we'll look at the Vancouver coastal experience. So the first thing to really underline here is there are no telephone TPA sessions recorded here. If they were, these numbers would be vastly higher. We can get Phil to speak to that later. But they have been doing a lot of TPA around the province. They've either been shipping them into Vancouver Coastal or managing over the phone. So their telephone numbers would boost those up. But what we see over time is an increase in the actual numbers, which are the dark columns in each case, the dark red and the dark blue. Beside it is the kind of anticipated, expected numbers. And I think if you were to add in those telephone consultations, then those numbers would be right on course. We would be getting just as many as was anticipated. But the most important thing you see is that the numbers are gradually rising in any event. And if we saw the video ones, we'd see they're rising, and we'd see the audio ones, they would be shrinking over time. So what did we learn from this? If you give us the next slide. Incidentally, out of the Vancouver coastal experience, half of the video cases were thrombolyzed. So 1 in 2 were thrombolyzed, which is actually higher than the Ontario experience, where I think it's closer to 1 in 4 get thrombolyzed. And maybe that's just what happens with time, as there's patients are vetted with lower thresholds. So this pilot project was implemented during times of significant fiscal restraint, which is creditable, that they're able to get it going under those circumstances. I think we've achieved expected TPA volumes. It's feasible, it works technologically, even when we have to cross multiple bridges and different healthcare regions. We've been able to get the MSP codes for stroke, and they're the best in Canada, I think. There's, I think, an appreciation in these sites that you now have a neurologist on tap as a backup to help. What I didn't mention is that for our Nanaimo site, certainly they are no strangers to giving TPA themselves, and so we're essentially there to help them out when there's more of an issue. So I've had, a young 20-year-old patient who initially was done with telestroke, and it was clear as that she had a brainstem stroke, that she was going to die based on the CT angiographic findings, and shipped her down to Victoria, where we were able to put a catheter up into her brain and lyse a clot that otherwise would have killed her, and that the intravenous TPA was just not doing enough of a job on. So the drip and ship mechanism that Vancouver does a lot of works through this. We had a physician who had a stroke a few weeks ago who I was disturbed to see that it took a physician to get one site to go and crank up the telestroke where they hadn't used it for a while. I think that speaks to something that needs to be addressed at any rate. But he did well, thrombolyzed. I think we have managed to get some feedback from going back to the sites, and Helen and others here have worked very hard to try and understand what are the barriers to implementation. And those sites that have gone through this have kind of dealt with some of these legacy issues like the PIA documents and such and brochures, which would be helpful for other sites in getting going. So I think I should, we're close to wrapping up here. The next slide. The challenges, I think, are if you're a site and you want to do this, you've got to be sure that you're ready to treat stroke. You've got to get everybody involved. The emergency room physicians are a big part of this. There still is a residual Flat Earth Society who believe that TPA doesn't work. It's an unfortunate piece because people are getting sued for not using it now. And we've moved on from the notion of whether it works or not to understand that it works in a graded fashion, as Phil showed you before. The earlier you use it, the better it works. Yeah, that kind of data doesn't come from a drug that doesn't work. So there may be some educational piece that may be needed in the emergency room. Neurologist involvement, I think, has been reasonably good overall. I don't think that that's been altogether a challenge.
No, it hasn't.
No.
Not at all.
It has been a challenge trying to address who's going to be the most responsible physician. You know, when I give TPA, I'm the MRP, and I'm hanging around making sure that things don't go wrong and answering questions. If you're a remote site and you want to do this, you may have emergency room physicians who just don't want to take over MRP status on somebody given TPA, and you may have an ICU doc who is reluctant to get down to the emergency room to take it over in a timely fashion. But when it works well, we see the emergency room physician be the MRP, give the drug, and then we are all still on video when we hand over to an internist who takes them upstairs. And data. It's always important to collect data. We don't know what we're doing without it, but it's a challenge in a busy ER kind of situation.